told that the evil spirits that were inside the person would leave them and they would become healed. But obviously, that wasn't the case. They were really suffering from mental illnesses. And in the early Christian period, they thought that sin or demons were possessing individuals, and that was the cause of their mental disorder. So clergymen would treat these patients oftentimes through exorcisms. There used to be a show on TV too a long time ago. My sister used to watch it, and it kind of was like a documentary about there's still clergymen out there today that will treat patients through exorcisms, but this isn't really the appropriate treatment nowadays. So if the clergymen weren't able to treat the patients through exorcisms, then oftentimes they would exclude them from the community, and sometimes they would even put them to death. So later in the Middle Era, contaminated environments were thought to cause mental illnesses, and patients were removed from their contaminated environments or sick environments, and they were placed in these one-room homes or asylums. And they were placed together, and oftentimes these homes were disgusting, they were gross, they were dirty. The patients had to shower together. Sometimes they didn't really have a place to go to the bathroom, so a lot of people would go to the bathroom on the floor. And patients were driven to these homes or asylums as a way to ostracize them from the community, or they were kind of taken away from their relatives. And you can read more about this too in your book on Table 1.1. So Philip Pinel, he was a physician, and he ordered the removal of inhumane treatments. So he was a big advocate for humane treatments. And first, the humane treatments started in men's hospitals. And Philip, he was responsible for bringing the humane treatments to patients with mental illness, and he ordered all the patients be under the care of a physician. And it wasn't until several years later that the same standards were put into the female hospitals as well. So William Tuke, he raised funds to host mental disorder retreats. So at the retreats, patients received sympathetic care in quiet, pleasant surroundings. And they were taught working skills as well, such as like weaving and farming, so that when they were recovered or they were able to manage their disease, they did have some kind of skills to go out and earn some money and work. In the United States, the Quakers opened mental health asylums that also had the humane and supportive rehabilitation. And as more states were founded over the years, new hospitals were opened, and these hospitals were dedicated to care for patients with mental disorders. But treatment still wasn't perfect yet. It still wasn't great until later on. So Horace Mann, he said that the insane were wards of the state. So therefore, state governments were mandated to assume financial responsibility for the care of people with mental health. And after the states were designated as being financially responsible for the treatment of their residents with mental disorders, the next step was ensuring that each state had appropriate funds. So Dorothea Lynday Dix, she advocated for humane treatments, and she was responsible for much of the reform in the mental health care system. And she was also responsible for the development of the first state hospitals. So she was very important in mental health. So this slide just gives you some information on mental health between 1900 and 1950. So during this time, institutionalization was the primary treatment. And institutions had a negative rap during these times because patients were just placed in these facilities, oftentimes for months, years, and these patients had very little hope of even re-entering society, even going outside. So they were very isolated, and they were isolated from their families and the community as well. So again, patients were still treated pretty poorly, and they still did not know how to care for individuals with mental health illnesses yet. So Clifford Beers, he was an advocate for humane treatment for patients with mental illnesses. And Clifford Beard had also had a mental illness himself, and he had experienced a lot of these inhumane treatments. So he later formed the National Committee for Mental Hygiene, which advocated for other mental health services. A lot of these services included child guidance clinics, they had some prison clinics, and they had some industrial mental health clinics, so some mental health clinics in the workforce. And Sigmund Freud, he was very instrumental in the mental health movements, and we'll talk a lot about him this semester. So when World War II came about, it changed the view of mental illness. And mental illnesses can affect pretty much anyone. We're all at risk for developing a mental illness, and no one is exempt from getting a mental illness. So if we don't have a good support system, if we don't have good coping skills, we can develop a mental illness. And like I mentioned earlier, if we have a lot of stressors in our life, that can be a precursor to also developing a mental illness. Certain mental health acts have come into existence that benefit individuals with mental disorders, and we will get into those as well. So what is psychiatric mental health nursing? The definition is a nursing practice specialty committed to promoting mental health through the assessment, diagnosis, and treatment of behavioral problems, mental disorders, and comorbid conditions across the lifespan. So mental disorders occur across young children to older adults. So some of you guys at your clinical site, there might be adolescent units or pediatric units in the mental health hospitals. And then I know at my clinical site, we have the adolescent unit and we have the adult unit. And then a lot of the local hospitals have pediatric units. So mental disorders can occur, like I said, in very young children to older adults. You have to be a certain type of individual to deal with patients with mental health needs. It's not for everyone. You have to have a lot of patience, trust me, a lot of patience. And if you don't have patience to deal with someone with a mental health disorder, then mental health nursing may not be for you. But you do have to understand that no matter, even if you don't like mental health clinicals, you do have to understand no matter which area you work in, there are going to be patients with mental illnesses. So Patients with mental illness first present in the ED. So a lot of you said you wanted to go into the emergency room. Some of you said you were texting the emergency room. So I'm sure you've seen patients with mental illnesses being brought in. Also, patients with mental disorders also get sick. So you will have patients with mental disorders if you work on a medical floor, if you work in the ICU, even if you work on a pediatric floor. If you want to go into neonatal, you're going to have to deal with a lot of parents, and some of those parents could have mental disorders. So you're going to see them no matter where you work, and you're going to have to learn how to care for them and how to communicate with them. I know when I worked med-surg, I had a patient, and it seemed like I got him every shift because a lot of nurses didn't want to deal with him. He was aggressive, he was mean, but once you really got to sit down and talk to him, he was dealing with a lot. He had PTSD from being in jail, and he was put in jail because he acted out. He had a mental illness, and that mental illness went untreated, and he got in trouble in society, and he got put in prison. He got jumped in the shower. So that was one thing that we really had to work hard with him on, is personal hygiene. He wouldn't shower. He was scared to get in the shower. So it is something that you're going to have to learn to deal with no matter where you go to work. And you're going to have to learn how to help these patients and how to build that trusting nurse-patient relationship with them. Oops. All right, so what does it mean to be mentally healthy? What do you guys think? What does it mean to be mentally healthy?
I would say just knowing how to cope with like everyday life stressors.
Mm-hmm. Yeah, so you could have, stress, or you could even have a mental illness, but if you know how to, if you develop healthy coping skills, or if you learn to manage your disease, you can be mentally healthy. So when we know mental health falls on a continuum. So on one end of the spectrum, we have the good mental health, and having good mental health, like you said, you're able to recognize that you're stressed, but you still are able to function in the presence of some type of adversity. So some type of loss, death, or some type of event, everyday life experiences. But on the other end of that spectrum, you have mental illness, where maybe individuals, they have emotional problems, they're stressed out, and that stress can range from mild to severe. It's going to cause impairment in their everyday functioning as well. So it can lead to individuals not eating, not sleeping, changes in their thought process, mood and behavior. So having good mental health is an emotional and psychological balance and the pursuit of wellness and meaningful quality of life. So it's an important part of overall health. And your physical and mental health are closely connected. So it's important, or it is impossible to be healthy without being mentally healthy. So when someone has a mental illness, it's going to affect their thinking, their thought process, and their mood and behavior. So think about someone who is experiencing thought distortions, and maybe they're paranoid, they're experiencing hallucinations, and then they may think people are out to get them, and their hallucinations or the voices in their head are telling them not to take their medications because individuals are trying to poison them. And eventually maybe the voices say, don't take that insulin. They're trying to poison you. That's not really medicine that's going to help you. That's poison. And then that individual's physical health will be affected if they listen to those voices and they don't take their medicine. So therefore, it is absolutely impossible to be healthy without being mentally healthy. But it is impossible to be mentally healthy and have a chronic mental disorder. So an individual that has a chronic mental illness can be able to adapt. They can make changes in their life. They have good insight about their disorder. They know they have to take their medications. They know their limitations. They know what will happen when they get stressed. So they're aware of those things and they're able to incorporate healthy coping skills. They're able to reach out to resources in the community to help them maintain emotional and psychological balance. So our mental health is important. And if we don't have good mental health, it can lead to a disorder and even suicide. So this is just another slide that organizes mental health for you. So again, mental disorders are conditions involving altered thinking, mood or behaviors, and are associated with distress or impaired functioning. When does mental disorders become a problem? What do you guys think?
When they harm themselves or others.
What else?
When it disrupts their daily life.
Yes. So if their mental disorder starts impairing their daily life, that can become a huge problem. All right, so let's talk about public stigma. So stigma is a huge factor that causes individuals not to seek help for their mental disorder because of what people say about them. So stereotypes lead to prejudice and discrimination. And when individuals do not have good knowledge about certain disorders, it will lead to prejudice and discrimination. So a lot of you guys said a lot of things earlier. Some people were saying that people with mental health or mental illnesses are violent, or they're faking it. They're dangerous people. So those are some stigmas. You also said that the media portrays them poorly, it is coming out that it's starting to get better, but in the past they've portrayed them as dangerous individuals. So all these public stigmas, it can lead to self-stigma as well. And what is self-stigma? It's when an individual will start believing what they hear and they'll internalize that because they internalize that and self-stigmatize themselves, that leads to label avoidance. And label avoidance, that's when an individual is going to avoid treatment in order not to be labeled as what they have been hearing the public refer to them as. But the thing is, we as nurses have to do better. And how do we counteract the negative effects of public stigma? So we have to change the culture surrounding the stigmatizing labels on people with mental illnesses. We have to interact with patients with mental disorders. We have to learn about them, and we have to learn how to respond to them and how to communicate with them. So oftentimes we hear on the news too about individuals with mental disorders. They've lost their lives by police because the police They don't know how to interact with them. They don't know how to communicate with them, talk them down if they're being aggressive. And also, too, think about a lot of you said you worked in the hospitals, you've been in clinicals, and how often have you heard your peers or your coworkers, they've referred to patients, even with medical conditions, not just mental illnesses, they refer to them as the diabetic in room 2 or the schizophrenic in room 4, the anorexic in room 2. So we need to change our language on how we refer to our patients. Instead of saying the diabetic or the schizophrenic or the anorexic, we need to change our language to the patient suffering from diabetes in room 2, or the patient suffering from schizophrenia in room 4, or the patient suffering from anorexia nervosa. So it's important that we change how we refer to patients to also help change the stigma. So that is something very important to work on. It took me a while as a nurse to start saying a patient suffering from instead of a diabetic or schizophrenic. So let's talk about the criteria for diagnosing someone with a mental illness. So there's a diagnostic and statistical manual of mental disorders. It's also referred to as the DSM-5. And all of the disorders are in this manual, and there are criteria that individuals have to meet in order to have a diagnosis. So sometimes patients do not exhibit enough of the symptoms, and we cannot diagnose them. So we may say unspecified anxiety disorder or unspecified schizoaffective disorder. So sometimes the DSM-5 tool will list some signs and symptoms, and patients have to have like 5 out of the 7 symptoms in order to have a diagnosis. So again, if they don't have enough of the symptoms or they don't have all of the symptoms, they can list it as unspecified. If we don't do a good assessment on the patient, then it's going to lead to a misdiagnosis, which will lead to an inappropriate treatment plan that the patient probably won't follow. So sometimes symptoms can be misinterpreted too, and that's because of different things like culture. So in some cultures, some of the symptoms an individual may exhibit may be viewed as abnormal to some providers. So some of the social and cultural norms of different cultures other than our own can be used to label someone as having a mental disorder, when in reality, it's a normal behavior in their culture. So we do have to be mindful of that as well. Some cultures, they chant prayers. They kind of chant prayers to themselves. They chant prayers out on the street. There's certain clothings that some cultures wear. So for example, in Muslim cultures, women wear veils, but someone doing it in a non-Muslim culture, that may be viewed as abnormal. So we do need to look at the characteristics from different cultures and determine what is actually normal and abnormal. So we do need to be culturally aware, and we do need to make sure that we're making accurate diagnoses. And you can read about some different cultural syndromes also in your book in box 2.2. All right, this is the multi-axial diagnostic system that the disorders will fall under. So axis 1 is your clinical disorders. So that would be like your anxiety disorders, depression, panic disorders, substance use disorders. Axis 2 is personality disorders and mental retardation. So some personality disorders would include antisocial, narcissistic, schizoid, and schizotypical, or typical, sorry. Axis 3, those would be your general medical conditions. So diabetes, hypertension, pregnancy would fall under Axis 3. Axis 4 would be your psychosocial or environmental problems. So some examples may be loss of a spouse, loss of a pet. Some environmental would be maybe living in poverty, being homeless, maybe having some legal problems, maybe not having a job. And then Axis 5, that's the overall functioning and global assessment functioning, so the GAF scale. So the GAF scale is a set of questions that you would ask the patient to see how the disorder is affecting their everyday functioning. So recovery is the single most important goal. We do want our patients to recover. We want to give them hope that they will recover successfully. And mental illnesses and emotional disturbances are treatable, and recovery is the expectation. So we want the individual to strive to reach their full potential. And recovery is a process of change through which individuals improve their health and wellness. They live a self-directed life, and they strive to reach their full potential, like I said. So these are some different components of recovery. We want to provide individuals with hope so that they can live successfully. We want to promote their independence. We don't want them just relying on other people. We want them to be independent. We want them to be responsible for their own care throughout their journey. And we do want to respect them as well. They want to be respected just like we do. They want to be accepted by society and communities, and they need a lot of support and peer support. And we can build on their strengths as well. So if an individual has strengths in certain areas, or they have good qualities in a certain area or certain skills, we can link them up in the community so that they can build on those skills. And that will help motivate them and let them know that they can lead a meaningful life. So recovery may be nonlinear, and what I mean by that is we expect that they may have some setbacks on their journey of recovery, and they may relapse. They're human and they're not perfect, but we want them to learn from their experiences. We want them to have continuous growth. I will say too, you do have to give individuals a lot of support if they do relapse. A lot of times these individuals are very embarrassed to come back to treatment, embarrassed to come back to inpatient, and they need to know that exactly what I said, that they're not perfect. It's going to happen and it's okay, but they do need to learn from their experience, and they need to learn that it can be better again. A holistic approach, which includes the mind, body, spirit, and community. We're not just focused on their mental disorder. And we want to empower them to choose their own options. We want them to participate in their decisions of their care. Their treatment plan should be unique and individualized. It should be patient-centered, and it should fit that individual and their culture and their needs as well. So these next few slides, we're going to go over different cultural beliefs. So we're going to start with Hispanic Americans. In studies indicate that Hispanic Americans tend to use all other resources before seeking out help from mental professionals. So many believe that mental health facilities do not accommodate their cultural needs, such as like the language that they speak, their beliefs, their religious beliefs, and their values. So many still seek help through supportive home care and counseling through churches rather than going to like a hospital. And CARESAT, if bilingual and bicultural mental health facilities are available, a lot of times people from different cultures will go to facilities that speak more than one language or that will accept their cultural beliefs. So many African Americans have extensive family networks in which members can be relied on for support. So older adult members are treated with great respect. But African Americans with mental illness suffer from the stress of double stigma from their own cultural groups and from longtime racial discrimination. Diagnosis and treatment often are racially biased, leading to less access of care because of the lack of health insurance. Generally, Asian cultures have a tradition of denying or discussing the existence of mental illness. In many Asian cultures, it is an embarrassment if a family member is treated for mental illness. It may be important to educate the families about the disorders, and maybe even possibly going to family therapy, learning about their loved one that has the disorder, learning about the disorder, educating them how to manage this individual that has an eating disorder and manage other family members who are being discriminatory towards them. Asian Americans may also experience culture-bound syndromes such as neurasthenia. It's neurasthenia, which is characterized by fatigue, weakness, poor concentration, memory loss, irritability, aches and pains, and sleep disturbances. And they also have Wambug or suppressed anger syndrome, and it's characterized by subjective and expressed anger, sensations of heat, and feelings of hate. So Native American cultures, they emphasize respect and reverence for the earth and nature. So healing and treatments include a lot of herbal medicines, a lot of healing ceremonies and feasts. And traditional views about mental illness vary among the tribes. In some tribes, mental illness is viewed as a supernatural possession, as being out of balance with nature. However, the degree of stigmatization is not the same for all disorders and varying among tribes. Mental illness, cultural beliefs, and poverty. Poverty is widespread among all cultural groups. Financial and emotional stress can trigger or exacerbate a mental illness. And individuals can feel trapped and in a downward spiral with increasing tensions and stress. They can feel powerless and have low self-esteem, especially if they can't provide for their families. And the homeless population is the most at risk for being unable to escape poverty. So they're kind of stuck. Most mental health services are located in urban areas because that's where most people live, near the city. Therefore, those living in rural areas have limited access to healthcare, and this can lead to fewer people being diagnosed with mental health problems. And this can be very problematic for children and older people who have specialized needs. So even though rural residents are less likely than urban residents to have mental health diagnoses or receive mental health care, the suicide rate is higher in the rural areas. And then spirituality and religion are factors that may influence beliefs about mental illness. So spirituality can have an influence on how individuals make connections to life, and it helps them interpret life events. It can also give individuals a source of hope, joy, and comfort and guidance on life's journey. And then religion as well. So religiousness is the participation in a community of people gathering around common ways of worshiping. And religious beliefs often define one's relationship within a family and a community. So sometimes, if someone is religious, it might help them, especially if they have suicidal thoughts and tendencies. And we'll talk about that later when we talk about suicide. But a lot of religions, will say things about, that committing suicide could be a sin. So it could help people not commit suicide as well, which could be a benefit. All right, and that's the end of chapter 2. It's almost 12:30, so I'm gonna go ahead and give you guys a break, a 10-minute break. So be back around 12:40.
I have a quick question.
Yes.
So how do you recommend taking notes and studying for the test? Is it basically reading the chapters and taking notes out of the book, or how will we be tested?
Yeah, I would read your readings and take notes during lectures. And then we will also do some class activities, and I'll have some activities for you guys on Blackboard too that you can study from too. So all of those things, lectures, and the activities that we do in class, or that we do on Blackboard.
So the readings, even if they're not on the PowerPoint, those could be testing material, right?
Yes.
Okay, thank you.
Mhm. All right, we're going to go ahead and get started on chapter 4. All right, so we're going to talk about some patient rights and ethical and legal issues. So let's start off by reviewing some of the legal and ethical concepts. So the first one is beneficence, and this is the duty to act to benefit others. So an example would be maybe holding a dying patient's hand, or performing daily tasks for patients who are unable to carry them out alone. That would be beneficence. And then we have autonomy. And autonomy is respecting the rights of others to make decisions. So in other words, patients have the right to make decisions about their medical care without their healthcare provider trying to influence that decision. And there can be a conflict between autonomy and beneficence. When the patient is being guided by the principle of autonomy, and then the nurse is being guided by the principle of beneficence. So for example, a patient wants to stop taking a medication, that would be autonomy. But at the same time, the nurse urges the patient to continue that medication because it would benefit the patient, which would be beneficence. So there can be a conflict at times between those two. And then we have justice, and justice is the duty to treat all fairly and distribute resources equally. And justice is kind of an issue in mental health and in regular medical health. Like we talked about earlier, when a certain part of the population doesn't have access to healthcare, basic goods that can't be distributed equally. So, there is some disadvantage to living outside of the city, and members also don't have equal rights to healthcare. If you have a good job, you might have good healthcare, but if you don't have a good job, you don't have good healthcare. So it seems like sometimes those means aren't distributed equally, and that can be a disadvantage. And then we have fidelity, and this is maintaining loyalty and commitment to patients. So basically, it's keeping promises. So fidelity is important in establishing trusting relationships. And a good example of this would be a nurse promising a patient that she won't tell his family that his diagnosis is terminal. Because they may disregard his wishes, and they may try to keep him alive no matter what. So that would be an example of fidelity. Veracity is the duty to tell the truth. So we expect our patients to tell the truth about their medical history, their treatment expectations, and other relevant facts. But at the same time, healthcare providers need to tell the truth about diagnoses, treatment options, benefits and disadvantages of each treatment option, and the cost of treatment. So the patient's civil rights and due process includes client consent, communication, freedom from harm, dignity and respect, confidentiality, and the right to participate in their own treatment plan. And we'll talk about these a little bit too. And also, patients with the mental illness have the right to fair treatment. So we're going to talk a little bit about self-determinism. And self-determinism is the empowerment or having free will to make moral judgments. And a self-determined individual is internally motivated to make choices based on personal goals. So personal autonomy, making choices for themselves and their healthcare, and avoidance of dependence on others are key values of self-determinism. Self-determinism is a basic and fundamental psychological need. Self-determinism is important for the recovery process. Why do you think that is? Why do you guys think self-determinism is important for recovery?
Someone's outlook and motivation affects how successful they'll be.
Yeah. So they need to want it. If they make their own choices, it will help them stick to, their treatment plan a little bit better. So in mental health care, self-determinism is the right to choose one's own health-related behaviors, which at times differ from those recommended by professionals. A patient's right to refuse treatment or to choose the second or third best healthcare recommendation rather than the first, and to seek a second opinion are all examples of self-determinism. However, it can be tricky with patients with mental disorders because their ability to choose treatment can be an issue just depending on the individual's competency, informed consents, if they're voluntary or involuntarily committed, and public safety. And we'll talk a little bit about that too. So because people with psychiatric problems are vulnerable to mistreatment and abuse, there are laws that have been passed to guarantee them legal protection. So the Patient Self-Determination Act was put into place and states that healthcare facilities receiving Medicare and Medicaid reimbursements are to inform patients at the time of admission of their right to be essential part of any and all healthcare decisions that are made about them. So they do have autonomy in their treatment plan. So patients have the right to be provided information about advanced care documents. Patients should be asked on admission if they have an advanced care document. And it should be recorded in their medical records as well if they have one. And patients should be provided with information on their rights to complete advanced care documents and any documents about refusal of treatments. So individuals with mental disorders, they may be unable to make decisions regarding their treatment and their care. So fortunately, there is advanced care directives, and these are legal documents that have been written, or they're written instructions about the individual's healthcare wishes. So these documents are made and created when the individual is competent, and can be used when they become incompetent, so that their healthcare wishes are still carried out. And then there's also a living will, and that states what treatment should be omitted or refused in the event that a person is unable to make those decisions. A durable power of attorney is an appointed proxy. Usually it's a relative or a trusted friend, and they're put in charge of the healthcare decisions for that individual in case that person becomes incapacitated. And then psychiatric advance directives are relatively new legal instruments, and it allows patients, while they're competent or while they're in the kind of recovery phase, they can make documents about what choices of treatment and care that they want in the instance that they become into their active phase of their disease and they're unable to make any decisions. But with the psychiatric advance directives, it does have to be signed by 2 witnesses. And it does have to be made in advance too. The Bill of Rights for mental health patients was put into place to give individuals with mental disorders additional protection. And you can read about these 2 in your book. It's on page 30, and it's box 4.1. The Americans with Disability Act ensures that individuals with disabilities, such as severe mental disorders, have legal protection against discrimination in the workplace. So an employer is free to select the most qualified applicant for the job. But if the most qualified person has a mental disorder, this law mandates that the reasonable accommodations need to be made for that individual. Internal rights protection systems are mechanisms to combat any violation of patient rights. And then there's a Public Law 99319, and it's the Protection and Advocacy for Mentally Ill Individuals Act, and it requires each state mental health provider must protect and advocate for the rights of individuals with mental illnesses and investigate any incidents of abuse and neglect. And then you also have external advocacy systems, which are organizations that operate independently of mental health agencies, and they serve as advocates for treatment and rights of mental health patients. The accreditation is recognized. The accreditation is the recognition or approval of an institution according to the accrediting body's criteria. And in healthcare, there's a few different accreditations hospitals or healthcare facilities can receive. And you might have heard of some like the Joint Commission. Usually mental health centers are accredited by the commissions on accreditation and rehabilitation facilities. Sometimes you'll see like the stickers in the windows. In caring for patients receiving mental health services or treatment, it is important for nurses to understand several issues related to the patient's rights to determine choices about his or her own treatment. And these issues are related to competency, informed consent, least restrictive environments, and types of treatments. And we're going to go over each of these in the next several slides. So competency is the degree to which the patient can understand and appreciate the information given during the consent process. So that individual So does that individual have the cognitive ability to process information at a specific time? So a patient may be competent to make a treatment decision at one time and then not competent at another time. So although competency is a legal determination, it's not clearly defined across the states. So how is it determined that a patient is competent? There are 4 areas that should be assessed to determine competency. A patient who is competent to give informed consent should be able to achieve communicating their choices. They need to understand relevant information. They need to appreciate the situation and its consequences. And they need to use a logical thought process to compare risks and benefits of treatment options. So they need to have all of these in order to give informed consent. And you can read more about these 2 on table 4.1 in your book. Individuals seeking mental health care must provide informed consent, which is a legal procedure to ensure that the patient knows the benefits and costs of treatment. To provide informed consent for care, the patient must be given adequate information upon which to base decisions and actively participate in the decision-making process. Informed consent is not an option, but it is mandated by state laws. In most states, the law mandates that a mental health provider must inform a patient in such a way that an average reasonable person would be able to make an educated decision about the interventions. Informed consent can be complicated in mental health treatment because a patient must be competent to give consent, but an individual's decision-making ability often is compromised by their mental illness. If hospitalization is required, then there can be different types of treatment. If an individual voluntarily admits or commits to hospitalization, then that individual maintains all civil rights and is free to leave when they want to. Even if it is against medical advice, they can still leave. Involuntary admission is the mandated treatment without the person's consent, but they do have to have a court order. The treatment can be inpatient or outpatient. It just depends on what the court thinks is best and what resources are available. In order to be involuntarily admitted, an individual must be mentally disordered, dangerous to their self or others, and unable to provide for basic needs. So again, patients who are involuntarily committed have the right to receive treatment, but they also may possibly have the right to refuse treatment. This just varies from state to state. And there's 3 common reasons someone may be involuntarily committed. And one is being mentally disordered, being a danger to themselves or others, and they may be unable to provide basic needs. In most states, emergency short-term hospitalization is 48 to 92 hours, and can be authorized by a certified mental health provider without a court approval. And then at the end of that 48 to 92 hours, the individual either agrees to voluntary treatment or they get a court ordered for involuntary commitment. Note too that patients normally have autonomy, so if they can refuse medication or therapy or groups, this is not cause for involuntary treatment. So if they're out in the regular world and they refuse going to outpatient therapy or they refuse medication, that doesn't necessarily warrant them being involuntarily committed. It's just usually if they're out on the streets, they're yelling, they're disturbing people, they're threatening people, that could possibly warrant for them being involuntarily committed. If they're trying to harm other people, harm themselves, then they could be involuntarily committed. The right to refuse treatment is related to a larger concept, the right to be treated in the least restrictive environment, which means that an individual cannot be restricted to an institution when he or she can be successfully treated in the community. Medication also cannot be given unnecessarily. And an individual cannot be restrained or locked in a room unless all other less restrictive intentions have been tried first. So which would be the least restrictive? Placing a patient in like a secluded room or restraints?
The room.
Yeah, so putting them in a secluded room would be less restrictive. So this slide shows you the steps of least restrictive to most restrictive. So the least restrictive first would be just observing the patient. Then you would try to de-escalate the patient. And try to get them to calm down. If they haven't calmed down or you can't de-escalate them, then putting them in a secluded room. If they still cannot be de-escalated after being in a secluded room, then you would put them in restraints. So privacy and confidentiality are rights that need to be protected for mental health patients. And privacy refers to the part of an individual's personal life that is not governed by society's laws and government intrusion. Confidentiality is the ethical duty of non-disclosure. Providers who receive confidential information must protect that information from being accessed by others, and they must resist disclosing it to others as well. So confidentiality involves two people, the person who disclosed the information and the person with whom the information was shared with. If confidentiality is broken, a person's privacy is violated. But a person's privacy can be violated, but confidentiality maintained. So an example of this is maybe you're walking past a patient's room and you notice they're reading a book on how to cope with bipolar. And they're alone in their room reading this. Then their privacy has been violated because you've seen this now. If the patient asks you not to tell anyone that they're reading this book, and that request is honored, then confidentiality was maintained. So breach of confidentiality occurs when A private patient information is released without his or her consent in the absence of legal compulsion or authorization to release that information. So, for example, discussing a patient's problem with one of his or her relatives without the patient's consent is a breach of confidentiality. So even sharing patient information with another professional who is not involved in the patient's care is a breach of confidentiality. And this has actually been quite big, especially now with COVID, about coworkers breaching confidentiality. It seems like at the beginning, a lot of people were scared of COVID, scared about catching it. So I know it was very common in my workplace where someone from a different unit would come down and be like, so-and-so has COVID. Well, that's breaching confidentiality because people on another unit may not really be caring for those patients on another unit. Health Insurance Portability and Accountability Act, or HIPAA. We all know about HIPAA. So the patient authorization is necessary for the release of information, with the exception of that required for treatment, payment, and healthcare administrative operations. When information is released, the patient must agree to the exact information that is being disclosed. The recipient of the information and an expiration date for the disclosure of the information is included. The American Recovery and Reinvestment Act focuses on maintaining privacy of electronic transfer and storage of health information and communication. In the clinical area, one way of maintaining privacy is by restricting access of records to like staff members. There's only certain staff members that can access certain records. At certain times, healthcare professionals are legally obligated to breach confidentiality. If a patient has harmed any person or is about to injure someone, professionals are mandated by law to report it to the authorities. The legal duty to warn was a result of Terrace versus Regents of the University of California. And in this case, a 26-year-old graduate student told the university psychologist about his obsession with another student. And her name was Tatiana Tarasov, whom he later ended up killing. So there was a bunch of lawsuits that were filed against the psychologist and against the university, and now professionals are mandated to warn potential victims. So again, you can breach confidentiality if a person is threatening to harm themselves or others. Nurses and healthcare professionals are accountable for the care provided in mental health. Legal liability and psychiatric nursing practice includes these terms. Assault is the threat of unlawful force to inflict bodily injury upon another person. And an example may be a nurse threatening a patient that she'll tie him to the bed if they try to get up. That would be an example of assault. Battery is the harmful or offensive touching of another person. Medical battery is the same as battery, but in a medical setting where a healthcare professional causes harmful or offensive touching to a patient. And this can occur when a patient is treated without giving consent. So for example, if a doctor does a non-emergent procedure on a patient without obtaining consent first, this would be considered medical battery. Another example of medical battery is failing to respect the patient's advance directives. False imprisonment is restraining a patient without legal justification or consent from for the convenience of staff. I've actually had a staff member be accused of this, and then I got yelled at for it by the patient's son. But there was an elderly patient, and he was given Ativan because he was just being disruptive, I guess, on the night shift. And in order to calm him down, they gave him Ativan, and I guess they did not get consent from the patient's son, and he was in charge of all the medical decisions. So I have seen this done before, and it wasn't a good situation. Another example of false imprisonment is facilities not discharging voluntary committed patients upon their request. Negligence is doing something or failing to do something for a patient that an otherwise responsible nurse would do or not do. So for example, a clinician who gets consent but does not disclose the nature of the procedure and the risks involved, that would be considered negligent. Or a nurse who pulls a urinary catheter without first deflating the and that causing the patient pain and damage to the internal structures. That would be another example. Common areas for lawsuits include patients who are suicidal or violent. Careful documentation is important to ensure protection of patient rights and nurses' accountability. If you do not document, then you didn't do it. So documentation that can be handwritten or electronic. Nowadays, it's mostly electronic. And nurses are required to document observations of the patient's subjective or objective physical, psychological, and social responses to mental disorders and emotional problems. They're to document interventions implemented and the patient's response. So if you give a PRN medication for anxiety, you would rate their anxiety, and then later you would go back to the patient and ask them to rate their anxiety again and ask them if that medication was effective. You're also to document observations of medications, therapeutic and side effects, and evaluation of outcomes and of interventions. Pay particular attention to the reason patients are admitted. If a patient was admitted for suicidal ideations or attempted suicide, that patient should be routinely assessed. Even if the treatment plan does not specifically identify suicide as a potential problem, if they've had it in the past or they've experienced it, then that would be something good to still do, is to assess them. You could even check in with them once a shift too, just to see how they're doing. Careful documentation is always needed for patients who are suicidal, aggressive, or restrained. Medications prescribed PRN are also require proper documentation, such as the reason for giving the medication, the dose, the route, and the patient's response to that medication. Was it helpful or was it not helpful? Those things need to be documented. These are some terms that have to do with if a person with a mental illness commits a crime. So sometimes a mental illness is recognized during the arrest for a crime, in which a forensic mental health team will become involved before the trial begins. And if a mental illness is not recognized, the individual may be sentenced to prison without treatment. So once in a correctional facility, if a mental illness is diagnosed, prisoners are treated in prison, or they can be transferred to a mental hospital for treatment and then return to prison once their treatment is completed. A possible outcome of a hearing or a trial is not guilty by reason of insanity. So the accused is judged to not know right from wrong, or to be unable to control his or her actions at the time of the crime. And the rationale underlying this ruling is one of fairness. So it is unfair to hold a person responsible if that individual does not know that their action is wrong, or does not have control over his or her behavior. So after a not guilty by reason of insanity is ruled, the individual goes to a forensic facility for psychiatric evaluation and treatment recommendations. And those treatment recommendations and the evaluation is submitted to the court. And almost all individuals found not guilty by reason of insanity are also involuntarily committed to a secure setting. And only the court can discharge these individuals from treatment or from the hospital. And then there's guilty by mentally ill, and that is a criminal conviction, and the individual is sent to the correctional system. Mental illness is considered a factor in the crime, but not to the extent that the individual is incapable of knowing right from wrong or controlling their actions. Both guilty by reason of insanity. Excuse me. Sorry. Both not guilty by reasons of insanity and guilty but mentally ill persons are treated for their disorders, but one is treated in a hospital and the other is treated in jail. All right, and that's the end of chapter 4. Let's see what time is it? All right, let's get started on chapter 6 and see if we can get that in today. It's a pretty short one. How are you guys doing? Are you doing okay? Do you need a break?
Is there no chapter 5?
No, there's not chapter 5. You should read it. It will be useful, but there's not a chapter 5 lecture.
Will we be tested on chapter 5 possibly?
possibly you should still read it. It will help you in future lectures as well. Sorry guys, I'm getting my stuff together here. All right, so this is chapter 6, the biopsychosocial framework, and it's a holistic model for organizing the patient's healthcare issues or problems. And when you guys do your nursing assessments, you will pull assessment data from the physical domain, the psychological domain, and the biologic domain to help deal with some of the patient's healthcare problems that they're experiencing along with their mental disorder. So with the biologic domain, some of the assessment data you will be obtaining from the patient would be asking them about their activity level. Some medications that the patients are prescribed, some of the psychopharmacological agents, they may cause the individual to feel fatigued. So you want to assess their activity level. Some of the disorders, especially schizophrenia, which we will talk about next week, some of the negative symptoms of schizophrenia includes fatigue or loss of energy. So it's very important that you're asking them and assessing the activity level. Some medications cause sleep disturbances. So you want to ask how many hours of sleep are you getting per night? If they're suffering from PTSD and suffering from night terrors, they may not be sleeping. So some medications they're prescribed may make them sleep too much. Some may cause them to be lethargic. Some medications will affect their appetite. So you always want to ask about their nutrition status as well. How many meals are you consuming each day? Some medications may cause anticholinergic effects. So some things like their mucous membranes may be drying up. They may be experiencing constipation. So you need to be asking and assessing this as well. A lot of the SSRIs or the antidepressants, which we'll get into later this semester, but a lot of those drugs cause sexual dysfunction, even some of the antipsychotics. So you want to ask about their sexual activity too. And then assessing what types of medications your patient is taking. You also want to assess the patient's understanding of why they're taking their medication and if they are administering the medication properly. This is one of my biggest pet peeves is when a patient does not know why they're taking a medication. So make sure your patients know, even if they're, a little bit younger. Sometimes I'll, tell my adolescent patients like, hey, did you know your medication was increased? Do you know why you're taking this? A lot of times the adolescents are better than the adults. They'll ask why. What's this medication for again? Like, why am I taking this again? So it's very important that your patient knows why they're taking their medication and the proper dose. They know how to take their medication. And this is important too for recovery and managing their mental illness. If they don't know why they're taking their medication, they don't know what dosage they're taking, it could eventually lead to a relapse. So it's very important that your patients know their medications and why they're taking them, what side effects they may experience or they could experience. They need to know all of those things. The psychologic domain, you will be assessing the patient's thoughts, feelings, and behaviors. So their interpersonal skills, are they able to interact effectively with other individuals? You will be assessing their thought process. So for example, someone who's experiencing mania with mental health diagnoses, you cannot do a blood test to determine if they have a particular mental disorder. So you will have to do the assessments to ask their thoughts, feelings, behaviors to help you formulate a mental health diagnosis. So you'll ask them about their thought pattern. Are you having thoughts of harming yourself? Is their thought pattern realistic, or is it distorted? Ask them about their feelings. Are you experiencing sadness? Are you experiencing anxiety? Ask them about their behavior. Are you more aggressive than usual? Those are all things that you can ask your patient. The social domain, you're going to be assessing how social factors or forces are affecting the patient's ability to function with their mental disorder. So you're going to be looking at their support system. Do they have a good relationship with their family? Is their family involved with their care? Do they have access to resources that they need in their community? Or do they have a ride to resources if they're, further, if they live in like a small town and they need to get to a big city? Do they have transportation? Do they know about the resources that they do have access to in their community? Some patients don't know about some of the resources that they have, so they do need to be educated about it. Family dynamics. So again, having that good support system and having access to resources in their community. All of that will play a role in that patient's recovery. It will affect how they respond to treatment and their overall functioning with their mental illness. So once again, the biopsychosocial model of mental health, it's all intertwined. So one area affects another. So you may see like in the middle here, under mental health, family relationships. If they have a poor family relationship, it could affect them psychologically. It could affect them with how they interact with other people. So they can be intertwined as well. All right, so these are just some tools of the psychiatric nursing practice. The most important tool of psychiatric nursing is self. So we need to be aware of our own values and our own beliefs. Knowing ourselves will help guide us. It will help guide us on how to interact with the patients. It helps us to be able to have a good nurse-to-patient relationship, which is very important. Clinical reasoning and reflection depends on our ability to critically think and being able to problem solve, being able to make decisions and evaluate and analyze what is going on with the patient. And this takes time. We'll gradually develop these skills and we'll eventually get there. I mean, it's something that you always work on as a nurse. The ability to understand when a patient needs medication, knowing when to intervene, knowing when a patient's mental status is changing, knowing that I went into the room this morning and the patient was alert and oriented, and then later went into the room and the patient wasn't aware of their surroundings. And they may be disoriented. So something has changed, and you'll develop those skills, and you'll be able to act or provide interventions in emergency situations when you develop those different types of skills. Actually, when I first started as a nurse, I just remember one of my patients, she was fine 1 minute, and then the next minute she had a full-blown anxiety panic attack, and she was breathing. I could tell she was breathing, but she was crying. Her eyes were just fixated, and she wouldn't respond to me. And being a new nurse, I was just like, what do? I don't know what to do. Like, I felt really dumb in this situation, but I immediately called the on-call doctor at the time. Instead of looking at the patient's medications, looking at her PRN medications to provide her something, I just was so scared about what the patient was going through. I didn't even stop to think, like, what should I do next? Like, what interventions should I do next? So of course the on-call doctor said, well, you can give her 9 o'clock medications now. It was 8 o'clock, so you can give them an hour earlier, an hour late. So she had some anti-anxiety medications that were due at 9 o'clock. It was 8 o'clock. So of course, give those medications and then see if it helps. But I mean, eventually, as I got older as a nurse, got more experience, I kind of know a little bit more now about what to do, what kind of interventions to take in certain situations. But you always want to reflect on your skills, reflect on areas that you need to improve in, and that's all part of growth. It's definitely scary as a nurse. Other people's lives are in your hands, but you learn as you go, you become more confident, you learn all these skills, and it'll be fine. Interdisciplinary care. You're going to be expected to collaborate with other disciplines and other professionals. So every patient has a care team. There's different people on these care teams, and it's very important that you're able to collaborate and work together for the sake of your patient. So it does take everyone to provide care to that patient. You're going to have physicians, you're going to have social workers, you're going to have dietitians. Some patients may even see therapists. So you'll have to, again, like I said, learn to collaborate with the other disciplines for the betterment of your patient. Because at the end of the day, we all have the same goal. Our goal is that we want the patient to get better. We want the patient to recover and get back to their normal daily living. And in order to do that, everybody has to work together. Plan of care. So nurses have to work, again, with the interdisciplinary teams to create treatment plans. And those are individualized to the patient's needs. I always tell my coworkers this, but nurses are, very important in patient care plans. We're the ones spending probably the most time with our patients. So it's important that we contribute to their plan of care, that we're telling their teams what's going on, their physicians, their social workers, just letting them know, keeping that open line of communication with them. All right. And that's the end of chapter 6. Let's stop sharing just for a second. Okay, so we're going to go over the last 2 chapters tomorrow that I have. Does anybody have any questions on any of the materials that we went over today? I love you guys being interactive in the chat. That's awesome. I'm sorry I don't really see it when I have my screen pulled up, but I like that you guys are talking to each other. You're talking to me. All right, well, I know this week's information is a little bit boring, but it's things that are important to know. It's things that you will be tested on. It's things you're gonna have to know as a nurse. And we will get into more interesting information after this week, but I know tomorrow we have someone coming in to talk a little bit about a study that they're doing. So I sent an email about it too. There is some information from one of the instructors that she's doing a study. So she's going to talk to you guys about this study in the morning. And then we'll jump into our last 2 lectures, and then we're going to do some learning activities. So I'm going to put you guys in the breakout rooms tomorrow. And then after we're done lecturing, and you guys will do some of learning activities, and we can go over those too. As far as quizzes, someone was asking about quizzes. I will let you know when you have a quiz, probably like if we were to have a quiz next week, I would tell you that we would have a quiz next week. So we'll either do quizzes or we have some other learning activities that will count as quizzes. We have a few escape rooms that we're going to have you guys do, and you'll get quiz points for those as well. So I don't know if that answers whoever asked that question. Okay. So yeah. But if there's no questions, I will see you guys tomorrow. And we'll go over the last 2 lectures tomorrow.